Okay, hi everybody, welcome. My name is Sue Evans. I'm the Director of the Victorian Cancer Registry and I'm chairing today's session with Angela Brennan. Welcome to this third and last session of the day. The session is titled Innovations in Access to Health Data, Unlocking the Power of Big Data. The session runs till 4:15. I know we're running a little bit late. There's what's an online conference without some technical glitches. First of all, I'd like to acknowledge the traditional custodians of Australia. I pay my respects to elders past, present and future of all Aboriginal and Torres Strait Islander nations. I pay my respects to the traditional owners of the land where I am based here in Melbourne, those of the Boonwurrung people of the Kulin Nation. I'd like now to introduce Angela, my co-chair. Angela is the Program Manager of the Victorian Cardiac Outcomes Registry and the Project Manager of the Melbourne Interventional Group, run by the School of Public Health and Preventive Medicine at Monash University. The summit wouldn't be possible without the wonderful support of its sponsors. Our gold sponsors are the New South Wales Department of Government and Bellbury Limited. This session has been sponsored by Medicines Australia and MTP Connect. I'm so pleased to be chairing this session because we've got three outstanding speakers. Each speaker will speak for about 12 minutes now. We've cut it down a bit and there'll be a panel afterwards for your questions. So I'd encourage you to post any questions you may have under the discussion, or you can submit your questions to the facilitator only under the ask. Any questions you post in the discussions area will be seen by all delegates. We'll try to get to all questions, but if we don't, please reach out to the speakers via email. We'll put them in the chat. Anyone working in the big data space in Australia will know Louisa Jorm. Louisa is the Foundation Director of the Centre for Big Data Research in Health at the University of New South Wales. This is the first research centre dedicated to health research using big data. Louisa's got a very strong track record, and I don't have time now to go through it, but because in the interest of time, we'll move straight into Louisa's presentation, which is on privacy and open access to health data. So thanks very much, Louisa.
Thank you so much. Could you just confirm that you can see my slides?
Yes.
Great. I just very briefly also like to pay my respects to the traditional owners of the lands that we're all meeting on today, and I'll try to get through this as quickly as I can. Just quickly to say that I don't have anything to disclose with regards to this presentation. In this presentation, I really wanted to sort of introduce you to, if you're not already familiar with it, the 5 SAFEs framework, which has really been adopted, I guess, as a national approach to protecting privacy and confidentiality of sensitive data. It actually originated from the UK, and basically sort of this approach of there are 5 SAFEs or 5 areas of control, all of which together can provide a framework for protecting data. So we have safe projects, safe people, safe data, safe settings and safe outputs. I'm very briefly going to step through a few issues that are arising with each of those 5 SAFEs currently as we work to try to implement them. And probably many of you will be aware that currently the federal government has a draft, it's called the Data Accessibility and Transparency Bill, and which is sort of working its way through consultation processes. And importantly, the underlying thrust behind that bill is to make data more accessible and make data used more for public good research and other purposes. But this best practice guide to applying the data sharing principles was released last year by the Office of the National Data Commissioner, and it actually takes the 5 SAFEs approach, although in this case, it renames the SAFEs data sharing principles. But I encourage you to have a look at that report and also all of the consultation materials around the draft bill if you're interested. So moving quickly through the SAFEs, safe projects, the idea of this is this particular proposed use of data appropriate? Trying to implement this immediately raises a couple of questions, one being who decides whether this is appropriate or not, and is ethical approval required? And if there's more than one person making this decision, how do you reconcile the different interests in declaring a project safe? So in terms of who decides, I think Australia perhaps hasn't moved as far ahead as some of our neighbours and colleagues. New Zealand in particular over several years has had a thing called New Zealand's Data Futures Partnership. It's an independent group that is actually tasked with working with both government and communities to help put forward the idea that data are a national asset for all, and to gain sort of consensus views on what are appropriate uses of New Zealanders' data. We don't have a similar sort of consultation process in Australia currently, and so there probably is a bit of a lack of social license currently around how do we use our data. I wanted to raise this, probably quite relevant to this audience. Traditionally, government data custodians have often been the ones who said this is appropriate or this isn't. Communities and people who in fact are the people who generate the data are usually left out of these conversations. And the Join Us initiative, which is an initiative of the George Institute and UNSW, is about trying to directly approach individuals who are interested in joining a register and participating in research. The idea, it's ambitious, is to engage 1 million Australians and pre-consent those to being contacted about clinical trial and other research opportunities, and also agree to use of their routinely collected data, both to identify them as potential research participants and to follow up the research, whether it be a trial or a cohort study. Go and look at the Join Us website if you're interested to know more. It's sort of undergone a soft launch, and a sort of hard launch of Join Us will be happening probably early in the new year. My second question was, is ethical approval required? And I think many of us don't realise that Australia has much more restrictive policies regarding exemption from ethics review than many other countries. And I take as a model the Netherlands, which is very explicit about stipulating that you do not require ethics approval other than for studies that expose participants to treatment or require them to follow behavioural rules, i.e. clinical studies or public health intervention studies of various types. But very, very explicitly designated in the Netherlands is an exemption for secondary use of data that does not include personal identifiers. And if we could only follow the lead of the Netherlands, there would be a huge streamlining of our current multi-layered and confusing approvals process for determining whether a project is appropriate or not. I won't go into this, but there's also quite a lot of questioning around about whether the ethics current HREC sort of composition and expertise of HREC members is actually what we need in the era of big data, when the considerations that we need to think about are really quite different to those that have been important in traditional research studies. Safe people. The safe people principle is about, can the researchers be trusted to use the data appropriately? Questions that arise here in trying to implement this are, do we need some form of trusted user accreditation? And how can we better equip our researchers to be safe people? In terms of trusted user accreditation, the Data Accessibility and Transparency Bill is proposing that there will be accreditation of both organisations and individuals who will be sharing public sector data in Australia. And at this stage, the detail isn't, fully developed, but many other countries do have approved researcher schemes. And watch this space. Development of this will be part, I guess, of implementation of the new Act once passed. And I think it's important that researchers have big input into the design of that scheme, so it becomes an enabler rather than yet a further barrier. How can we better equip researchers? One thing that strikes me constantly is how little material is included in the undergraduate and postgraduate coursework that many of us have studied, and around things that are really important in the era of big data, things like IT security, like statistical disclosure control and how to do it. And I would advocate for greater content in existing courses, but we also need specific safe researcher training, which will probably form part of the accreditation of users under the new Data Accessibility and Transparency Act. In terms of safe data, this is around, is there a disclosure risk in the data itself? Two questions arise here. How do we balance disclosure risk and the utility of the data, and can we? And also, how can we reduce waste and duplication in data management? And in terms of balancing disclosure risk and utility, I would argue, maybe some of the other speakers will have a view on this, that unit record data that has any utility for research or analysis basically is not appropriate to be released as open data in the current environment, where there is potential for data to be brought together from multiple sources to potentially create disclosure risks. Release of things like a 10% sample of the MBS and PBS, even with direct identifiers removed on the internet, is simply something that should not happen and will not be happening in the future. So basically, that's why we need the full 5 safes framework, rather than a concept of certain data are safe enough to be released on the internet. In terms of reducing the current huge waste and duplication in data management that results from every project being treated as an individual and separate project, what we need to be thinking about are sort of large and high value data assets. And again, our New Zealand friends, I think, are doing better than we are in this regard. They have a thing called the Integrated Data Infrastructure. Don't have time to go through it in detail, but basically brings together public sector data, census, health data, income and work, justice, population for the entire New Zealand population, and makes that available in various ways to researchers. Brings it together once, makes it available for many, many purposes. We're lagging behind in development of these high value data assets in Australia. In terms of safe settings, the question here is, does the access facility limit unauthorised use? There are questions here about which data should be open, which ones don't need to be in a safe setting, and what should a safe setting prevent. I've already sort of answered this question. From my view, is that no unit record data that hasn't been basically created as a synthetic data set should not be open. In terms of what should a safe setting prevent, we've got various approaches. On the left there, we have this safe pod, which is a UK-based approach where poor researchers have to lock themselves in a little room with no windows, and basically every move that they make is videoed. Every mouse click that they take is recorded. So it's a totally closed sort of environment. While in Australia we have a range of other approaches, which are basically remote access data laboratory facilities. What do they prevent? They basically prevent malicious acts by hackers. They prevent stupid behaviours by researchers in terms of accidentally sort of downloading data. But nothing can prevent using the sorts of facilities such as Erica, Shore, there are others. Nothing can prevent malicious acts by users in terms of doing things like photographing the screen. That's why one needs to have a sort of a full 5 safe approach, where only a safe user, someone who actually has undergone training, is an employee of an accredited institution, is allowed to access data. Safe outputs, the question here, are the statistical results non-disclosive? Again, questions that arise here, what methods should we use to ensure they're non-disclosive? And again, many of us don't actually have any formal training in statistical disclosure control methods. And then secondly, who should do the checking? I think a lot of people will find this document recently released by Data 61 and CSIRO, the de-identification decision-making framework, a really useful read and a way of actually learning about the various approaches to de-identifying data. In terms of who should do the checking, the issue here is that it can create big bottlenecks if every output needs to be checked by, for example, an employee of a government agency or a statistical agency. It becomes unfeasible once large-scale research use and analytics start to happen. And again, I think an approach that accredits individuals to do the checking is going to be needed unless we want the safe output step of the 5 safes to become a bottleneck. So here we are back at the 5 safes. I'm sorry I've had to sort of race through this faster than I would have liked, but finally wanted to bring to your attention the Australian Real World Data Network, or RADIANT. It's basically a researcher-led network which has about 300 people from across Australia and New Zealand. Its main role is to advocate on behalf of researchers in the whole range of government policy processes around access to data that are currently happening. And I think it's fair to say that RADIANT and the multiple submissions it's actually had an impact on the drafting of the new legislation, and we will continue to work with the Office of the National Data Commissioner as it rolls out to try to get a regime in place that supports researchers, meets our needs, while still protecting the privacy of all of the members of the Australian population whose data hold such value for research. Thank you.
Wow.
Excellent.
Thank you, Louisa. What a lot of information. I didn't know anything about the de-identification decision-making framework, but that's something I scribbled down very quickly because it sounds like it's going to be an incredibly important document. Now we're going to hold questions for the panel. So please make sure that if you've got questions to ask, you jot them down and put them in the discussion section on the live studio so that we can ask them to the panel. But I'm now going to introduce our next speaker, who also heralds from New South Wales. I'd like to introduce Professor Tim Shaw. Tim is the Director of Research in the Digital Health Cooperative Research Centre, or the Digital Health CRC, as we all know them. Established in 2018, the CRC brings together academia, industry, government and service providers to transform healthcare. So Tim today is going to talk to us about access to health data and impact on frontline care. So take it away. Thanks, Tim.
Great. And just as with Louisa, can you see my screen?
Yes.
Yes.
Great. Okay, you don't get notification of that. Thanks very much. And it's always good to follow Louisa's. And I think our talks are quite complimentary. So I guess what I wanted to talk about was more maybe some of the applications of health data. And I think the 5 safes is a great backdrop to what I'm about to talk to now. So I guess when I look from a very practical sense in terms of the spectrum of health data application, and what I'm seeing is kind of a convergence of usage of data, particularly around the health record and how we go about actually accessing that information, obviously in a safe way. I guess the other thing I'd really add to what Louisa was saying is I think the other thing we've really got to focus on is the whole social license to access this information to the group of, or to all of us as consumers of health data. And I think My Health Record really threw up in terms of the challenges of that. And if we don't get that right, I think we're not going to really get very far at all. So I look at health data running from point of care decision making, obviously where a lot of the electronic medical record or health record it focuses around, through to how that data is used to potentially support clinical trials, then through to the area I live perhaps most in, which is around practice review and quality improvement. So how do we pull that data through to there? And then more pulling, how does that data then flow into population health research? I see that as a continuum, largely being siloed up until now, but I think what we'll see over the next 3 to 5 years is a real breakdown in terms of the data sets that we use, and start to use more common data sets. And then that raises further questions about how we handle that in a safe and consented way. So the way I look at it at the moment, obviously we've got multiple data captured and retrieved multiple different ways. We've got large amounts of manual entry still into the system, multiple duplication of data, and I would still argue that at times, in terms of the real benefit that we have of having access to these type of data sets, we have limited downstream impact. So from my perspective, where I see we're kind of going with the kind of holy grail for some of this is obviously capturing single capture of data. Obviously that includes electronic medical records, devices, apps, and as well as obviously the explosion in personally controlled consumer data sets. How do we capture that data into single points or multiple points, if you like, but then how do we then seamlessly use that data for multiple purposes? Obviously I'm not underestimating the challenges involved in that, but rather than everybody doing their own capture, I think we need to look at greater efficiency. So I'm just going to talk about very quickly three use cases that I've been involved in, 2 from the CRC and one from the University of Sydney, and and just explore some of the issues that Louisa talked about before. So the CDAP platform, it's a clinical data analytic platform that we set up and funded through the Digital Health CRC. This is funded through eHealth New South Wales, eHealth Queensland and the Commonwealth. We've got Tom Snelling, Anne Nicholson, Matt Belgard and Nick Sepps as investigators on this program. We stood this up in February to say, look, obviously we have very limited ability in Australia to share and combine live identified data sets so that we can support immediate decision making across different organisations. So whether you're a doctor in Kalgoorlie or in Sydney, whether you can actually be able to tap into algorithms with your own data sets that are based on combined patient data sets from across the nation. We have no ability to do that at the moment. And also we have very limited ability to be able to do broad scale adaptive trials on the fly, because we just don't have combined health data sets across the nation. So we stood this project up. Obviously it's been luckily challenged because we haven't got a lot of COVID data in, or limited COVID data, patient data in Australia, but it's allowed us to really look at a number of these issues around governance of information across jurisdictions, how you have this combination of needing data to be able to sit in a central source so that you can do decision making as well as support adaptive trials and research. And it's drawn up a lot of these issues, and I believe Tom's talked about this project in another environment. I really like this one because it's crossing that border between decision support and adaptive or trials and research. The second one is a project that I'm leading around mobilizing health data for performance review and continuing development. This is one that we've funded from the Digital Health CRC. It's got the College of Surgeons, the College of Physicians in it, and 5 private hospitals, which has been really interesting in terms of actually working with the private health system and how they're starting to access and use data. So much of the focus tends to be on the public health system in Australia. So we've used multiple data sets here. And we're really coming from the perspective of how do we start to extract data, whether it's clinical or administrative data sets, how do we combine that with registries data and other pieces like health insurance claims forms, and how do we make that work for clinical teams. In this project, by early next year, we'll have 7 PhDs and 2 postdocs working on this program, and about 20 academic and industry supervisors, looking at the whole data lifecycle, but from a clinical perspective. So much of the outcome, so much of the data I think that we present to teams and individuals comes from the Quality Improvement Office, and through that lens, a lot of it's about looking for poor performance and rectifying that, rather than actually giving clinicians and teams access to their own data and allowing them to proactively manage that. So we're looking at the whole spectrum of how people, what data points most impactful for clinical teams, through to how do they visualize that, how do they learn from data, and then how does that pull through into continuing professional development. Again, I like this because it's taking that data where people would agree that data should be accessed potentially in an identified way by an individual clinician around their performance, then potentially around the team. But as soon as that pulls into quality improvement and further down the track into professional development, what does that mean about permissions and so on around the live identified data sets we need? Because the clinicians want to be able to dive into an identified case, not de-identified benchmark data so much. They learn from the identified individual cases. The final piece, I'm just moving quickly through this so we have more time for questions, is a project the University of Sydney's worked up for a number of years with Department of Health in New South Wales. And this has been led by Charmaine Tan, David Brieger, with Aldo Saavedra and Jonathan Morris. There's a whole team at university that's been working on this one. So this has been running for a couple of years now, where we're really looking at how can you extract longitudinal data around STEMI patients from electronic medical record data. So can you start to generate those kind of automated, almost registry type information? And it's been a challenging but rewarding project. Again, I won't go into detail. Charmaine, I know, has presented information on this project at previous ACTA meetings, but it's been really useful just to understand what we face when we're trying to attempt this type of on-the-fly data, and then how do you ultimately, once you capture that data, how do you present that to teams for the maximum impact? Just to give you some snapshots, so we began to start to be able to clearly map patient journeys from extracting this data, and they've already been useful. And really what we're looking at this one, or I guess the ultimate aim of the project, to say, can you start to capture this data in real time and then really present that back to the clinical teams for maximum impact? I'll just finish off with some general conclusions. So, as I mentioned at the beginning, I think we're entering a world of convergence of data for decision making through to performance review, professional development, and research. I think they've lived in different domains, but we're seeing that convergence occurring now. How close that gets is for debate, and it'd be interesting to see what James says about that. We often have discussions around this, but I think that's happening. We're seeing these kind of examples start to emerge, and that's pushing us together, which challenges some of the safe framework, I think, in terms of this merger between different aspects of usage of live data sets, and the blurring between what is research and what is support for clinical practice. Obviously I don't underplay the challenges in using these data sets. There's anybody that does it, I'm sure there's many in the room that do, around data quality and extraction, the real challenges of getting that information out. I'm a strong believer, though, that unless we start to demonstrate usage of these data particularly from electronic health records, then we're going to continue to have poor data in there until we show the value of actually putting better quality data in. The whole governance piece that Louisa alluded to, is ethics an appropriate framework for much of this work? I really think we don't have fit for purpose frameworks to support a lot of this, particularly the blurred kind of activity. Enormous problems around gaining dynamic consent and so on. So there's a world of work around that as we move into this kind of brave new world. And then just to underline that some of the challenges we've worked around, once you pull this data out of systems, even if you want to use it for immediate decision support back into systems, we're challenged to do that between two hospitals that are 10 kilometers apart from each other. Is even harder to do it when you start to cross jurisdictions and different regulations within that, and then potentially internationally. And then, as I've said, for me, I'm very focused on, once you've got this, how do you push that information quickly back into workflows and processes in a seamless way so that it has maximum impact on outcomes and care. I'll stop there.
Thank you.
Great, thanks so much, Tim. I'm going to introduce now our last speaker for the session, but please don't forget to put questions up. We've got the panel afterwards, and we do have time to pose questions. I know the speakers have been, whipping through quite quickly, but it does leave us some good time for the panel afterwards. So it's now my great pleasure to introduce our final speaker of the session, Professor James Boyd. James is coming to us from Melbourne. James is the inaugural chair in digital health at La Trobe University. Tim is an international expert in data linkage. He leads La Trobe's digital health strategy around course development and research. He's got over 25 years of experience working with large national data sets, and he has also been very much part of the team that put together the digital health CRC. So he would know Tim well, I'm sure. I'll leave it to you now, please, James. Thanks.
Hey, look, thanks for the introduction. Yes, and I'm going to split my talk between the digital health programme at La Trobe University and some of the work we're doing in the digital health CRC. So hopefully it kind of partners up with what Tim has said. I thought I would kind of talk a bit about the drivers for digital health and why it's become a very big area, and where the kind of focus of a lot of the research is going. And also there's a number of reasons why digital health has become such a focused area. Part of that's to do with the changes in technology that we've had, which is generating large volumes of digital data. And that has led to challenges around the technology we use to store and analyze that data. So big changes required to actually manage, manipulate, and analyze the data that's coming from different health technology. The other thing is obviously the demographic changes that we're seeing. So there has been changes in demographics. We have an aging population. We have a shift in the way we treat people. So we have more people with chronic conditions, and that has led to thoughts to how we actually manage that demand. The other thing I think that has happened is that we have consumers who are used to using technology to access services, to use different services, and they expect the same from health. So consumers actually expect to have the opportunity to interface with health services the way they would interface with any of their day-to-day services as well. So they have a real expectation that any of the health services that we're providing are discoverable and they can get real-time access to that. And the last part is that the technology isn't staying still. So we actually have a lot of changes happening, new things happening in the horizon. And it's about trying to put together the health services we have and the technology that goes with it in a way that's future-proofed. So I'm just going to talk about the changing models of care, which is also driving some of the change as well. I think we have an expectation of moving from acute care to chronic care, which is driving some of the change. We're looking at moving from treatment to prevention. I'm trying to think how we introduce technology to make that happen. Moving hospital to more treatment at home, and I'll come back to talking about some of the aspects of that have happened around the virtual care. I put physician-led to consumer-led, and I think that's probably too much of an extreme. There needs to be something in the middle, but I think consumers or patients and families expect to be involved in the care model. So physicians are starting to have to think about the communication they have and coming up with the model of care that fits the consumer with the consumer and their family. And probably the biggest one that we come across in terms of changing models of care and digital technology is around moving from paper-based to digital systems. So would you believe we still have lots of systems that are paper-based, which does kind of restrict how they can be accessed and what we can do with the information. So I've talked about lots of technology coming in to try and help what we're doing in terms of the health services. That means that we have a lot of information that comes from it. And part of the challenge is to try and take that information and use it in a very smart way. And I suppose based on the background you heard from at the beginning, I do come from a data integration or data linkage background. When I first came to Australia about 12 years ago, I suppose this is where I was in terms of the health systems, trying to think about joining together information that allowed us to see a patient's journey throughout their life. So starting at birth and ending at death, trying to think of the different hospital type systems that we could add together to actually look at the information for a patient in their pathway. The challenge with that in Australia, unlike in Scotland, is that some of the care is funded in different ways, and it means that the data is collected in different places. So there's a need to bring together some of the state and territory information with some of the Commonwealth information to get that complete journey. I suppose over the 10 years that I worked in data linkage in Australia, we moved from just the health to trying to think about other government services that impact and trying to understand people's touch points with different government services, all of which often have an impact on their health journey as well. So you know, we were able to link a lot of the health data. Other government departments realised that their data sets were very similar in terms of administrative collections, and that we could actually link those together too. So we started to get to this place where we had different types of government services all together, showing all the touch points a person has as they move along their journey. I think where we're getting to now is moving from this use of routine administrative data, you know, that well-defined, well-structured data that's collected against all government services. And I think Louisa and Tim mentioned the other places we get it. So some activity and cost data, the disease registry information, all which provides a lot more detail, but all with really strong definitions and standards. And where we're moving now is into a world where we're thinking about the Internet of Medical Things, wearables, social media, all this type of data coming in, being added together and understanding a lot more about an individual and where they use different health systems. The challenge with that is that all this comes and it brings less well-defined information and the need to be able to both integrate and manage and then make available structured and unstructured data. So a number of challenges about the way we think and the way we actually use the information. Now, I threw this in because it kind of shows where we are and where we're going. This was an article in The Economist in 2017, and asked healthcare professionals where they thought the big developments would be in health, where the technologies would impact over the next 5 years and then over the next 25 years. And you can see in the 5 years, and obviously we're in the middle of that period just now, there was talk about portable medical devices, so devices for medical staff to monitor patients, health sensors for consumers, so the wearables, the digital tattoos, all that kind of Internet of Medical Things, the medical devices doing remote monitoring, and obviously with a large collection of data, things like AI to improve medical decision support. In the 25 years, what people kind of highlighted were things like hospital redesign. I suppose that's that move from hospital to home, treatment in the home. Things like precision medicine, etc. And the biggest one that stands out to me is that the telemedicine. So people saw telemedicine to be a big factor in the next 25 years, but it wasn't in the 5 year. And I think the pandemic has changed that. So the advent of telehealth and virtual care has come in as a result of the pandemic, and COVID's kind of made a change to the health systems that are there, and that one has become a priority to us. So I just wanted to talk about where the digital health CRC has actually impacted some of the work we're doing, just building on the 3 examples Tim gave. Before I do that, the ideas of the CRC, and I hope Tim doesn't remind me going through this, the idea was to actually focus on industry problems and actually try and create partnerships between industry and academia to actually solve those problems. What we wanted to do in the CRC was cluster a lot of those so they weren't small problems and focus on the large and priority areas. And the other aspect of the CRC is that it's looking at education as well as research. So that was the aim. And as part of that, we kind of went round and tried to find different areas where we could break up the projects. From the foundations of the creations we have in terms of how we put systems together, the interoperability of them, through telehealth and mobile health, through digital health systems, into the data, big data analytics and the management of the information, and then into the disruptive technologies. Now, this is the way the research matrix went, so trying to put together some of the priority areas and then structure them across the locations that would happen. So a lot of work was happening in the home and work and primary and acute. We wanted to put some of the research priorities across them, but we wanted to focus on things like rural and remote, aged care and the rehabilitation. In the interest of time, I just wanted to talk about one of the responses that the Digital Health CRC made to try and help as the COVID crisis struck, and it was around telehealth. So we became acutely aware that telehealth was going to be something that was going to be significant during the actual COVID crisis. We were aware that some people had experience of telehealth and some had none, and we tried to put together a webinar series. It started with a one-off. We thought it was going to be an international one, which involved some participants from both the UK and Australia, and they talked about telehealth and the use of telehealth. And from that one, which was very well attended, we've actually created a whole series of telehealth webinars, which have been attended by over 5,000 individuals. And from that, based on the questions we had, we started to develop the telehealth resources. So trying to put together information that would support the community, help people starting up in telehealth, try to put people in touch, how to prepare clinicians, how to prepare patients, and just try to understand the challenges and connect people to provide the additional information. And that way, we've kind of managed to continue this. It's been really successful. And if you go to the Digital Health CRC web pages, you can actually get access to the telehealth information. I was going to talk about a couple more, but I think in the interest of time, I'm going to just leave it there and we can maybe answer some of the questions that have been said.
Wonderful. Thanks very much, James. Thanks to all our presenters. I haven't given them the credit that they deserve in introducing them. They've all got such an amazing track record and true expertise in the field. It's now time for us to open it up to the panel, and Angela and I will do a bit of a tag team on this one. But I might start by asking a question to Louisa. Louisa, this question comes from John Salzberg, and it's probably one that all of you have been asked. I know I have been asked it numerous times in the past. It's the question about to whom do these data legally belong? When we're collecting these large data sets, who becomes the custodian? Who is the person accountable for it all? And I wonder also maybe whether the New Zealanders have answered this one.
Ownership, interesting question, but basically the position is that the agency that collects the data owns the data, but under legislation that is present in some states and territories, also under proposed Commonwealth legislation, people can access data about themselves. They have the right to request access to their own records, but they don't own those records.
That gets difficult when you get large data sets, and it becomes hard to pull individual people out of them.
Well, exactly.
Angela, we might go to you for the next question. Thanks.
Thank you. So this question came through, James, during your presentation, and it's from Dr. Sanjaya, and it's related to the sharing of clinical notes from big health data sets, and that these could be useful in the context of mapping a patient's journey, which Tim had shared in his presentation. Do you have any intel into any names of any existing data sets that allow sharing of clinical notes? And are there ways to assist with accessing these and getting access to them?
Yep. Thank you, Angela. Strangely enough, quite recently I came across a company they approached me who basically create warehouse technology but use machine learning, artificial intelligence and natural language processing to try and read in some of the information that's not stored digitally. So they've actually created a system that actually can take the clinical notes, reads it in, stores it in a way that you can actually use it and present it back. So this was a piece of technology that was developed in the mining industry, which actually collected a lot of the information for mining, but they want to try and track out on a medical aspect. So think about exactly what the question relates to, getting clinical notes, storing that in a way that you can actually use it. Now, I'm not sure you hear me because I'm getting a lot of feedback. Is the audio okay?
Thanks, James. Tim.
Yeah. So look, I mean, I know of. I think this is what a lot of groups are working on is trying to create these longitudinal journeys. So, and look, I know when I was working with the breast cancer team at Westmead a couple of years ago, and I find it still remarkable that it's really difficult for a breast surgeon to get a longitudinal journey of her patient's profile over a number of years from an electronic medical record. I mean, to me, it's a massive fail. But I know that a lot of the big companies are working on that, and there's groups like Alcidion that are obviously in the business of looking at bringing together longitudinal patient journeys. I mean, I often think when you look at EMR data, it's like looking at somebody's letterbox. You can only see a little snippet of what you're looking at. And then there's big companies like HMS, who's one of our partners from the US, that have all the Medicaid data sets, and that's something they're very focused on, is actually drawing from those data sets to create more comprehensive patient journeys, but so that they can do near real-time outreach to those patients if they're going off track. So, I think there's a lot of people starting to bring these pieces together. I guess the challenge is what frameworks does that sit under? Is it under primary or secondary use of data? You know, see, there's some of the things I think we need to raise up. Whereas I think, you know, I see that as a primary use of data, particularly if you're using it for immediate outreach to those patients from those journeys that you're discovering.
I think the other point you made there. Sorry, Louisa.
Sorry, Louisa. I think you had your hand up first too. Apologies. Go, James.
Louisa.
Oh, James.
Sharing clinical notes, a really big challenge is the fact that clinical text contains huge numbers of identifiers of the patients, their family, of clinicians, and so that's one of the reasons it's been so hard to share. But there are technologies being developed in natural language processing to very much automate and streamline the de-identification of clinical text, which will make it potentially much more accessible for research and sharing, but it's always going to need to be within a safe environment of some sort and done by safe.
Thank you. Sue.
So, isn't it interesting that we're willing to share our data on Facebook and LinkedIn and everything else, but certainly health data, people are very protective of their own health data, and understandably so. As consumers, there's a question that's been raised that as consumers, there's quite a big concern over just handing over all our medical information to researchers, especially when it also goes through the DHHS or the Department of Health, and possibly able to be accessed by Centrelink. How do you propose that we should handle this?
That
Probably
question
Tim.
was for Tim, yes.
Yeah, I think it's a Tim question.
So I just got a little bit of feedback then. I apologize. Can you just repeat the question? Again, I didn't mean to speak over James. I didn't pick up the call. Can you just repeat the question quickly to me?
Look, I think what it asks is around concern by consumers that in agreeing to be participants in some of these studies and part of these large data sets, and especially where you were talking earlier about having one large central database, people are obviously concerned that their information doesn't just go to the researchers. It might also go through to other people like the Department of Health and possibly also to Centrelink. Is that fallacy? Is that truth? And whatever it is, how do you propose that we should address that issue?
Well, I mean, either way, we have to address it, whether it's true or not. I mean, I think there was a lot of, angst created around My Health Record of people with the record going to police, social services, and so on, which I think wasn't real, but I think obviously raised a huge amount of concern. And I think this goes to my point about social license. I don't think we've had a conversation. I mean, I had it with most of my family members. I'm sure you all did too, when the opt-out was going on about should they opt in or out My Health Record, and had that conversation with so many different people about, well, what would the data be used for and how can we use that? So I think we absolutely need to build up the social license for that. If you look at the CDAP project, where we very quickly wanted to stand up a project of combining data across the nation, we had a panel of consumers very quickly in the piece that we were working closely with. And I think there was the general view that you have to be clear about what you're using the information for and what the parameters are around that. You're not just seen to be going fishing, and it's really clear where that data is going. And so even in that case, you need to consent to that, and the population where that data is being extracted knows what's happening with it. I think it becomes harder and harder as we start to bring different data sets together where we don't necessarily know the usage of that data yet if we're using it in real time. So for instance, HMS in the US, when you join up to the Medicaid program, you give permission for your data to be accessed for the improvement of your care. And that means that can be a forward-looking thing that you have no idea what that's going to be. And that's a big step to take. And I think it's something we really need to look at as a society. I think it becomes more pertinent as you move from de-identified data sets for large kind of cohort, epidemiological studies to live identified data sets that are being aggregated. But then, we're also working with the Consumer Health Forum a lot. I wrote an article last week in their newsletter, saying that we've got to be careful we don't throw the baby out with the bathwater and lock it all down so that we don't benefit from this data. But then we've got to do it in a way that's secure and safe and visible and transparent in terms of what that data is being used for. And it's not an easy journey, but I think it was Angela, you said that my son's happy to share incredible things on Facebook and then gets terrified about, sharing data on a personal level. So it's a challenge. But I come down to, I don't think we've done enough of this as a society to have that discussion. I think it's fundamentally one of the big problems we've got.
Thanks, Tim. I'm going to ask a question, just something I'm interested in, which is about HREC. Louisa, you spoke about it, and James, you also spoke about it. And I mean, I don't think this can actually be answered in the time that we have, but and I'd love to know the answer to this question. So if it's not the traditional HREC, paradigm, what is it? And I don't really expect an answer to that. But James, you also suggested around the concept of consumers' expectations versus the reality. And how do we think that intersects with HREC? I think, it's two different questions, but the whole HREC sort of conundrum that we all face is something that perhaps, Louisa, you could give us a start, and James, you might chime in at some point. We might go over a couple of minutes, everybody who's tuning in. So thanks, Louisa.
I think, as I said, for the research use of de-identified data, my personal view is that we should not have HREC review should not be required. And I think that would dramatically simplify things if we could take that position in Australia, which we're actually one of the most restrictive in the world with regards to that. Clearly, that's only for the de-identified use, secondary use of data. But my own view is that HRECs currently don't apply consistent approaches to dealing with these projects either. And usually you have to go to multiple HRECs. And this is one of the big issues. You end up with different HRECs telling you have to do different things. The mutual recognition really is not fully in place currently with regard to the sort of routinely collected health data. It's sort of there, but it's not there. And it traditionally takes about 3 years to get ethics approval if you're wanting to collate a data set that involves data from all Australian states and territories. I don't think makes a lot of sense.
Thank you. James, any insights?
I think Louisa's expressed it really well. From the research side, there are a lot of processes in place. So governance is not quite as simple as people think to get access to different levels of data. As Louisa said, if it gets down to sensitive data that's potentially re-identifiable, especially if you want to link it, there are a lot of checks and balances that are put in place, and it can be long and time-consuming to actually go through all of those to get access to the data. So there is a need to maintain the checks and balances, but streamline that process for research. From the other side, I think, Angela, you were talking more of an operational. So consumers expect to get access to systems, I think, the way they would, to the different services they use through their phone or through the internet. And they expect to be able to book services. They expect to be able to get information about services easily without having to, go through some of the longer traditional approaches. And part of the job of the health service and government is to be transparent about what information it collects and how it stores that information and how it uses it. So there's a kind of expectation on both sides. Whereas researchers have to go through the HREC process, I still think there's a requirement for government to be transparent about what information they have and how they collect it and store it.
Thank you.
Thanks, everybody. Look, it's 12 minutes past 4 and we were due to finish at 4:10, so we're a couple of minutes over. I know that there will be lots of questions that people might have for the speakers, and I'm sure that the ACTA and the conference conveners would happily pass emails of the speakers to people who would like to direct questions to them. But in the interests of time, we're going to call it a day now. I'd just like to finally thank the 3 wonderful speakers, James, Louisa and Tim. And also I'd like to thank my co-chair, Angela, And the terrific organisation and the people that have been behind the scenes, and who's been plugging all the questions in, and Lizzie and Anita, who have been working diligently. And I'm sorry there were some technical glitches to start with. I do apologise for that, but please reach out to the speakers, and I hope you enjoy the rest of your night.
Thank you, Sue. Thanks
Thanks,
everyone.
everybody.
Bye.
Bye, everyone.